Hello, everybody. Welcome to another in the Decoding COVID seminar series. We started this series a few months ago at the beginning of the major part of the pandemic here in Rhode Island to have a place where we could learn more about what we were facing, to learn more about the disease, about the virus, about the public health impact of what was going on. And I must say that these sessions have been remarkably well attended. They've been remarkably filled with information. They have covered all various different aspects of this problem. And along those lines, we're going to be dealing with another really critical part of this pandemic in today's session. I don't have to tell the people who are listening in about the impact that the pandemic has had on every aspect of our lives. One of the most really, I think, horrible parts of it has been the disparities that have been seen in the impact of this pandemic on different communities within Rhode Island and within the United States and around the world. So we're thrilled to have two of our own speaking on this topic during this very important and very critical time. I'm going to let Sharon Rounds introduce our two speakers to you. Once again, thank you to the two speakers for coming. Thank you to all of the people who are tuning in for this seminar series. Sharon, take it away. It's all yours. Thanks.
Okay, great. Thank you very much, Jack. I'd like to point out that this particular Decoding COVID-19 seminar is co-sponsored by the Warren Alpert Medical School as well as the Brown School of Public Health. Could I have the next slide, please? We'll be talking about health disparities and COVID-19 next. Since we are offering continuing medical education credits for this event, I wanted to point out that the speakers and planners have disclosed they have no relevant financial interest to report. Next slide. And the Brown disclaimer and privacy policy is listed here. The CME office maintains its site as an information resource. Next slide. Today's presentation is accredited for 1 hour of AMA Category 1 credit and 1 hour of risk management credit. Next slide. Some additional information about the CME accreditation archive. Next slide. If you wish to claim credit for this live webinar, please email the Brown CME office with Decoding COVID in the subject, and they will provide you with information on the link. Next slide, please. I guess that would be the first slide of Dr. Grigsby's presentation. So it's my distinct pleasure to introduce two distinguished speakers today who are on the faculty of the Brown School of Public Health. Diana Grigsby-Toussaint is Associate Professor of Behavioral and Social Sciences and Associate Professor of Epidemiology. She joined the faculty of the School of Public Health at Brown in the fall of 2019, coming to us from the University of Illinois, Urbana-Champaign. She's a social epidemiologist, and her research is focused on the 3 pillars of health: diet, physical activity, and sleep. Amal Trivedi is a general internist and professor of health services policy and practice, and also professor of medicine. He's a hospitalist at the VA hospital here in Providence, and he is also a prolific researcher who studies quality of care and health care disparities. And We are just thrilled to have both Diana and Amal with us today. So one last thing to the audience, please enter your questions, comments in the chat function, and at the end of the seminar, we'll have an opportunity to address those. So without further ado, we would be starting with Diana, but
I will go ahead and get started. And that means I get right into the meat of things. So first I wanted to start with, what do we currently know about COVID-19? And the Johns Hopkins University has been great in terms of keeping us updated with respect to the number of cases, where we are globally. And so unfortunately, we've surpassed more than 6 million cases worldwide. In the US, we're fairly close to 2 million cases. And unfortunately, as of this morning, we've certainly surpassed over 110 deaths in the US. Across the US also, specifically in terms of looking at reported cases, we see that we have a lot of our cases concentrated in large metropolitan areas, certainly New York, places like Los Angeles. And within as we dig a little deeper, we see Boston, for example, New York, Los Angeles, and some of these places represent areas where we have high concentrations of Native Americans. With respect to the growth rate, we see about a growth rate of about 1% each day in terms of new cases. On average, there are about 20,000 cases being reported per day with respect to COVID-19 in the US, and we have about 1% increase in new deaths every day as well. In terms of Rhode Island, Rhode Island has actually done a really great job with respect to testing for COVID-19. The areas where we see the highest number of cases have been Providence, Pawtucket, and Central Falls. And so what's interesting to note about those areas as we talk about the disparities is that we find high concentrations of Latinos, for example, in Central Falls. And we find high levels of poverty in some of these areas in respect to where we see high numbers of cases, showing again, and we'll see how this plays a role when we think about, we'll talk more about the disparities. And so when we look at Rhode Island, especially thinking about race, ethnicity, and disparities, we find that although Latinos only make up 16% of the population in Rhode Island, they account for more than 44% of the cases. And we also see a disproportionate number of Blacks relative to their proportion of the population in Rhode Island. Across the US, we have been really alarmed at the number of cases, the overall deaths for African Americans relative to other groups, where we find that, unfortunately, African Americans, the rate of deaths are much higher, more than twice that of what we see for Blacks, as well as other racial ethnic groups. Sorry, what we see for whites as well as other racial ethnic groups. There are also concerns when we look at Native Americans. When we look at Arizona, for example, we see that although Native Americans only make up 4% of the total population, they make up 18% of the deaths. And certainly very concerning New Mexico, where Native Americans make up 9% of the population, but 57% of the total deaths. So we also see disparities in this group as well. When we look at COVID-19 deaths by age, we certainly see much higher deaths for elderly individuals as we go across age groups, where we certainly see an increase the older people become. And when we look across the US with respect to the percentage of deaths that we found across the US, and we look at across the US and look at nursing homes, we find that when we look at each state, that most of the deaths from COVID-19 a lot of deaths from COVID-19, a substantial proportion are coming from nursing homes and assisted living facilities across the U.S. When we look at nursing homes, another concern is that even within the nursing homes, we also see disparities when it comes to Blacks and Latinos. So for example, we find that for homes that had at least 25% Black or Latino residents, they were 84% more likely to at least have one case of COVID-19. And usually that's, if you have one case, there's a tendency where there's increased likelihood of then having a major outbreak of COVID. And so looking across all states, with the exception of New Mexico, we found that if there were higher concentrations of Latinos and Blacks in a nursing home, we saw that they were more likely to have cases of COVID-19. Then we also see, of course, one of the concerns we have is that this might be underreported with respect to excess deaths. We also see higher number of cases in jails and their National Commission on Correctional Care. There's several groups that have been collecting data with respect to cases of COVID-19 in jails. And we find, unfortunately, that compared to even within jails, we find that African-American inmates have higher rates. When we look over at hospitalizations, again, we find that Latinos, non-Hispanic Blacks are more likely to be hospitalized from COVID-19 compared to other groups. And then when we look at some of the underlying laboratory confirmed hospitalizations, unfortunately, some of the conditions that we find to be higher in African Americans and Latinos, such as hypertension, for example, higher rates of obesity. Unfortunately, these are medical conditions that we're more likely to see in these groups. And unfortunately, they're more likely, these underlying conditions, unfortunately, make the severity, increase the severity of COVID-19. So when we think about the cases of COVID-19, unfortunately, we have more than 6 million cases globally. The cases are increasing. In the US, we see about 20,000 new cases being diagnosed per day. And we also have racial ethnic disparities for African Americans, Latinos, and Native Americans. And we also, for the elderly population, as well as for groups for certain facilities where, for example, jails, as well as nursing homes. So what are some of the reasons behind these disparities? I think of this in terms of a social determinants of health perspective. When we think about the social determinants of health, we think about what are the things in terms of where we live, where we work, where we play, that ultimately influence our health. And that can be employment. We know that in the US, for example, employment is tied to health insurance. So if you are unemployed, there's a higher chance that you are likely to be underinsured. In terms of housing, when we think about COVID-19, we have talked about the importance of social distancing. But if you are in a house where it's difficult for you to self-isolate, that increases the likelihood of you then spreading that condition to others. And certainly when we think about, we'll talk a little bit about access to healthcare. Not only having access to healthcare, but then ultimately the interactions when you actually with the healthcare system. So as an example, we think about social determinants of health. And here we have a boulevard in St. Louis, Missouri, called Del Mar Boulevard, that separates a predominantly African-American neighborhood from a predominantly white neighborhood. And what we find is that we see major differences in terms of home values. And we know that home values are clearly a high indicator of wealth in the US. We see a high difference with respect to median income. We see educational disparities. We know that, for example, your tax base is associated with funding for public schools. And so how can we expect the experiences of the residents of these neighborhoods to be the same in the pandemic? Because clearly there are differences in resources with these two groups. So this comes from, you can also think about how education plays a role. So before COVID-19, before we had a travel ban, I had the opportunity to go to Mississippi in early March, and I went to the two, it's called the two Mississippi museums. And they really did a nice job in terms of showing over time disinvestment in salaries, teacher salaries by race in Mississippi from the 1800s through at least 1946, where you see where there's more parity early on, and then clearly there's a major disparity with respect to Black teachers versus white teachers, and what the implications are with respect to where you have a segregated system and what students are learning. In addition, we also see disparities with respect to what is spent on students over time, where for the most part, across time, we see that most of the funding for students in the Mississippi school system has overwhelmingly been for white students. So limited investment in education leads to limited opportunities for a living wage, and ultimately influences the likelihood of low-wage occupations. So we see here where, for example, some of the individuals that would be at high risk for COVID-19, for example, food preparation workers or people are making less than $12 an hour, or where you have nursing assistants. So groups, again, low wage, limited likelihood in terms of opportunities for positions or occupations that would make it much more difficult for them to separate or protect themselves from COVID-19. In addition, unfortunately, there's been historical precedent for the dehumanization when it comes to Blacks in the U.S. With respect to their interaction within the healthcare system. So here we have a narrative from a slave, John Brown, who unfortunately at the time was at the hands of a white physician in Georgia, and he wrote this in his narratives, where the hypothesis at the time was that Black skin was supposed to be thicker than white skin. And he talks about the fact that he was constantly had blisters applied to his body to see how he would recover, to test this hypothesis. And unfortunately, you would think that, after looking at this is his narrative was written in 1855, and this is a paper written in 2015 in the Proceedings of the National Academies of Sciences, looking at racial bias in pain assessment and treatment recommendations. And one of the things that was very disheartening was to find that among medical students and among residents, that there were still beliefs that Blacks had nerve endings that were less sensitive than whites, whites had larger brains than Blacks, or that Black skin was still thicker than whites. So again, we see questions of, as a result, it isn't surprising that we have issues of distrust when it comes to African Americans wanting to seek treatment. So we have this case of Reginald Ralph, a 50-year-old African American male who was suffering from a cough, some of the symptoms of COVID-19, but because he had dissatisfaction with his doctor with respect to that was treating him for diabetes, he delayed seeking treatment for COVID-19. When he finally did go to an urgent care clinic, he was sent home without a test because he didn't have a fever, although he had the other symptoms, and he ultimately died. So here you have his mother and his sister, and where they questioned whether whether there's a possibility that when he ultimately did go to the doctor, whether he would have been treated, he would have been tested for COVID-19 if he was a white patient. So one of the things that we also see with COVID-19 that we're seeing now is that we're seeing higher numbers of COVID-19, especially with African American patients, And the concern is that these patients are certainly more sicker, that they're delaying care, and some of that care might be due to distrust of the medical system. It could also be due to being concerned about leaving work. And so again, these are things that we have to think about. When we also look at Latinos, recently, they're here, since in Rhode Island, we have a high number of Latinos, unfortunately with COVID-19. The governor has done some work trying to making sure to reach out to Latinos within Rhode Island. And one of the things that has come up is that some Latinos have been concerned about going to get tested, especially if they are undocumented, being worried about accessing going to get these tests. One of the other things that has also happened is that the public charge rule that was implemented, that has gone into effect, essentially discourages anyone from going, from seeking care if they need it, especially for programs that might be related to food, for example, any of the support programs in the US, because if they do use any of these programs, it reduces the likelihood of them being able to become US citizens. And unfortunately, again, this, another concern in terms of undocumented Latinos, for example, or non-citizens being worried about going to get tested and then having to deal with issues around immigration. We also find that Latinos make up a high proportion of food production workers, one area where we have seen a high number of cases, especially if you've been tracking this in the Midwest, where we see a high number of COVID-19 cases in meat processing plants. And unfortunately, we have a high proportion of those workers being Hispanic relative to all workers in the US. So some work that we've been doing that we currently have under review, looking at just access to COVID-19 testing sites. We looked at this in New York City and found that overwhelmingly, a lot of the testing sites were in majority white neighborhoods and very few in Black or African-American neighborhoods. Even though it was a little better in Hispanic neighborhoods. And unfortunately, there were some areas, some majority African-American zip codes where there were no testing sites at all. And so this again speaks to issues of access with respect to testing. More concerning was that when we looked across the entire US, we found that of all the testing sites at the time we did this analysis in early May, was that almost 80% of them were in majority white neighborhoods, although we still have these high numbers of African Americans and Hispanics with COVID-19. One of the other concerns is that even with testing sites, there are issues where for the longest time, a lot of the testing sites were walk-up testing sites. Were drive-through testing sites. And so there were concerns where people would walk up and they would be turned away, especially with some of those testing sites in low income or lower income neighborhoods. So when we think about dimensions of inequity that are specific to COVID-19, and some of these things Amal will be touching on more, but when we think about some of the underlying social determinants, issues related to ability to socially distance, where we have, unfortunately, African Americans and Latinos being more likely to live in multi-generational households, where it's more difficult to socially distance, or because of their occupations, they have to go into work, they have to interact more if they work at a grocery store, for example, or at a meat processing plant. And then, also the fact that challenges in terms of access to testing, limited information in terms of who is being tested. I think last time maybe there might only be about 4 states that's reporting data by race ethnicity in terms of who is being tested, although we have more data by race ethnicity with respect to the number of cases or the number of deaths. And of course, we have racist narratives and stigma that are still of concern as people interact with the healthcare system. There being issues with access to the economic stimulus, where you had children born in the US, but their parents were not citizens. And so there were challenges with them even getting access to the stimulus to help address some of the, the economic issues as a consequence of COVID-19. So where are we now? We think about how these social determinants influence COVID-19 and what's happening with the cases. So one of the things early on, we know that sort of wearing a mask is very important. And we know that it's important, but unfortunately, many Black men, especially early on, were very concerned about wearing a mask because of COVID-19. They were concerned about being a threat, being seen as a threat. I even remember my husband, I had him put a mask on early because I said, well, I see what's going on before the CDC made his recommendation, because I looked at some of what was going on in China, and I saw that there were a lot of people wearing masks. And he was really concerned about going out with a mask, even to the grocery store, because it wasn't something that everyone was doing, and he was concerned about that. And I really had to talk to him and say, no, this is really important. It's something that you should do. And unfortunately, these fears have been well founded in terms of Black men being seen as a threat. We had the death, the murder of George Floyd, which has resulted in widespread demonstrations and calls for social justice. And so we hope we wonder where we go from here. We hope to see real reform as a result of what's going on. Unfortunately, too, one of the things that has occurred is that there are concerns that some of the testing sites that would have been placed in low-income or African-American neighborhoods, that some of those will no longer be the case. So the social determinants of health are really driving COVID-19. COVID-19 has really been an amplifier with respect to these. We already had these underlying societal factors. They've just been amplified as a consequence of COVID-19. And so we'll see what will happen as a consequence of some of the demonstrations, the protests that are going on, and the fight for social justice. And I'll turn it over to Amal.
Thank you so much, Diana, for that terrific discussion of what we know about drivers related to COVID-19, and bringing us up to date on the state of evidence about disparities following the pandemic. And I really want to pick up on that just terrific lead-in by focusing on the broader consequences of COVID-19 for social determinants of health. And then I want to close with some potential interventions and policy strategies to address disparities, because the point isn't to just continue documenting disparities, it's to ultimately end them. So I'm going to try to share my screen, and we will project some slides. Great. So Diana covered what we currently know about COVID-19 and disparities, also the reasons behind disparities. And I'm going to try to focus on the broader impacts on social determinants and disparities and then interventions. See if I can move this forward. Great. So when I think about COVID-19 and health disparities, first, we want to think about the direct effects from infection. And I think Diana covered this incredibly comprehensively in terms of the disproportionate impact of COVID-19 on racial ethnic minority populations in the United States with respect to mortality, hospitalizations, morbidity, clinical sequelae, and disability. And what I'm going to do in this section of the talk is focus on emerging evidence about the impact of COVID-19 on key social determinants of health. And I got to say, there's a lot to talk about. And in fact, Diana and I, when we were putting the session together, we thought we could probably spend an entire semester and not cover all of the relevant dimensions with respect to disparities in COVID-19. So I'm going to be just selective, but I want to highlight two key social determinants that are being impacted by COVID-19, and that's economic stability, which includes unemployment and financial stress, and then access to healthcare. When I say access to healthcare, both health insurance coverage and then the impact on safety net providers who disproportionately serve minority and low-income populations. All right, so this is a graph. We've seen this in the newspaper about weekly unemployment claims from 1967 to 2020. And the gray areas are periods of recession. And the key point to make here is that the loss of jobs during the first 6 weeks of the pandemic has been really unprecedented. Prior to 2020, the record in terms of number of new unemployment claims that ever occurred was in 1982, and that was about 680,000. The number that occurred in just the first week of the pandemic was 7 million, or over 10 times higher than the highest amount ever recorded over the last 50 years. And so this graph essentially needed an axis that was an order of magnitude ever presented in terms of capturing just the scale of job loss. Now, a lot of the coverage has been on the total amount of new unemployment claims, but the repercussions of job loss have not been shared equally. And so as Diana covered, Black and Hispanic Americans are more likely to be in jobs considered essential work. And that's work that puts these workers at much higher exposure for COVID-19. But this survey data from the Urban Institute shows that Hispanics and non-Hispanic Blacks are more likely to report losing a job, having a reduction in work hours, or pay because of the pandemic. So, the key point to make is that workers from communities of color are getting doubly impacted by the pandemic. First, by having greater occupational exposure to virus, and then by being more likely to be laid off or having their income cut. Now, when people lose jobs, they need to rely on accumulated wealth to cushion the blow. And that's why the impact of job or income loss is magnified among Blacks and Hispanics. This is a graph that shows trends in median family wealth for whites, Blacks, and Hispanics since 1963. And the gap is profound, and it's grown over time. In fact, in 2016, the median wealth for a white family in the United States is 10 times higher than that for Blacks and Hispanics. And the absolute gap has widened considerably over time. And this gap is actually much larger than the income gap. And the reason for that is that wealth compounds over time. And the disparity in wealth that we're seeing in recent years represents the cumulative effects of essentially generations of systemic racism, which includes slavery, Jim Crow, as Diana covered, segregation in low-income neighborhoods, and then redlining practices that denied Blacks systematically access to mortgages and steered Black Americans towards neighborhoods with higher concentrations of poverty. And that's a very potent driver of the wealth disparity because for most Americans, home ownership is the kind of the largest source of wealth for most families. And so that's why job loss is particularly concerning because it's not just the higher rate of job loss within minority communities, but it's also the impact among minority communities when there is a loss of income or when the people have lost a job. And that's shown on this next slide. This is a graph that shows, using the American Community Survey, the fraction of US families that have what's called liquid asset poverty. Liquid asset poverty means that a family does not have enough savings to pay for the basic needs, housing, food, and other types of supports for more than 3 months following a job loss. So about 3 in 5 Black and Hispanic families in the United States cannot cover basic needs for more than 3 months after unemployment. And that's why COVID-19 is having a substantial impact on financial stress and why it's an emergency to extend unemployment relief when it expires in July next month. So how does this reverberate to health disparities? And there is a robust evidence base from public health and from economics that shows that economic stress is associated with a range of important outcomes, including worse mental health, depression and anxiety, increased smoking and alcohol, housing instability, food insecurity, greater death rates. And there are important spillovers to children, including educational outcomes and mental health outcomes. So as providers, we're going to be seeing a lot of these repercussions, not from the direct effects of infection, or in addition to the direct effects of infection, but also the effects of the response to COVID-19 and the economic impact on social determinants of health. Okay, so let's go to the impacts on the U.S. healthcare system. This is what I focus on in my research. I've been studying the U.S. healthcare system for over a decade, and in my view, there are three core problems in U.S. healthcare, and COVID is making all of them worse. Here's a list of my top three. There are so many flaws in the U.S. healthcare system that you could add others, and I probably wouldn't argue with you. I think the first core problem is that we stand apart from every other high-income country in the world by not guaranteeing universal health insurance. Also, many Americans are underinsured. And for the majority of non-elderly Americans, insurance is typically tied to employment. And so we covered job loss earlier. And what this means is that in the United States, the trauma of job loss is often accompanied by the loss of employer-sponsored health insurance. And that's a kind of a peculiar form of cruelty in the United States, that as you lose your job, many people also lose health insurance coverage. And so, as I'll cover in the next couple of slides, what this means is that the pandemic is going to increase uninsurance across the country unless policymakers take specific actions to prevent that. The second core problem in US healthcare, from my perspective, is that most providers are paid on a fee-for-service basis, which means they're completely dependent on the volume, intensity, and reimbursement rates to remain financially viable. And so we will see how the loss of revenue is going to impact safety net providers, and safety net providers are critical in addressing healthcare disparities in minority communities. And then finally, another core problem from my standpoint is the inequality in US healthcare and the substantial documented disparities in care, and the fact that the US healthcare system is segregated along racial, ethnic, and insurance type, and that there is tremendous concentration of racial ethnic minorities within a small number of providers, and these institutions are often financially threatened and often unable to deliver high quality care because of the constraints. So there's substantial disparities in the rates of uninsurance. Here we can see trends in uninsurance for American Indian, Hispanic, Black, Native Hawaiian, Pacific Islander, and Asian groups. And the rates of uninsurance have declined markedly after the adoption of key provisions of the Affordable Care Act. But there are still substantial disparities in 2018. With American Indians and Alaska Natives having the highest rate of uninsurance, followed by Hispanics, Blacks, Native Hawaiians, all having higher rates of uninsurance compared to whites and Asians. I should say that although Asians have the lowest rate of uninsurance, the aggregate rate among Asians masks very important subgroup differences across Asian populations in the United States. Now, one of the key ways that uninsurance was reduced since 2013 was through Medicaid expansion. And this is a map that shows expansion in non-expansion states. Expansion states are bordered in red, bordered in black, and non-expansion states are bordered in red. And a couple key points is that there are 14 states across the country that have not expanded Medicaid. Those states have higher rates of uninsurance, and they have higher fractions of Black populations. And so in those states, when somebody loses health insurance because of job loss, they often will have no way to acquire Medicaid coverage. And so although we don't have empirical data yet on the loss of uninsurance or loss of insurance, the forecasts are very stark. This is a report from the Urban Institute and the Robert Wood Johnson Foundation. that estimates that about 25 to 43 million Americans are estimated to lose employer-sponsored health insurance coverage. The rate is going to be about 23%. It's forecasted to be 23% in expansion states, much higher loss of insurance in non-expansion states. And then even beyond that, currently the US Supreme Court is reviewing a case that is challenging the ACA. That decision is expected in the next year. And that if the court holds against the ACA, that would invalidate the entirety of the Affordable Care Act, including the insurance market reforms, the exchanges, and Medicaid expansion in all states, which would increase the number of uninsured by 30 million or more during a pandemic. So why does this matter? It matters because there is very robust evidence base that gaining insurance coverage has reduced disparities in access to care. It's also led to better health outcomes, including lower death rates, lower rates of bankruptcy, lower rates of housing evictions. Here's one example from our research group where we found that after Medicaid expanded in 2014, the one-year mortality rate for non-elderly patients starting dialysis fell substantially compared to what happened in states that didn't expand. And the effect was really large. We estimated that it would take about 18 such patients gaining insurance coverage to prevent one death in a year. And the effects are particularly strong or much higher for Black dialysis patients, demonstrating the potential for insurance coverage to reduce disparities in outcomes. And so that's why loss of coverage can threaten health disparities for minority populations in the United States. Okay, so let's talk about the impact on the use of healthcare. And this is not going to come as a surprise to many of you in the audience. There is a tremendous reduction in the use of healthcare services. They plummeted across all regions of the country, both in areas with high infection rates and those with low infection rates. Many hospitals have seen reductions of 50% or more in terms of lower utilization. And because hospitals are paid in the United States by the admission, that means lost revenue. And this is going to have a particularly large impact on safety net and minority serving hospitals. Many of them already had low margins and unfavorable payer mixes to begin with. And so there's a lot of evidence from our work and others that care in US hospitals is segregated and unequal, and that minority patients who receive care in financially threatened hospitals are going to likely see erosions in quality and access to care. And a lot of these dynamics are also very true for outpatient primary care. Community health centers are a vital component of the safety net. They deliver care regardless of insurance and the ability to pay. They also disproportionately serve minority and low-income patients. Many of these centers, because of the loss of revenue and the reductions in utilization, are either closing or furloughing providers. This map shows the percent of health center sites that have closed as of May 8th. And across the country, about 1 in 6 health centers is closed. And if that's prolonged, that will have fundamental impacts for disparities because of their vital role. All right, so we covered the impact on social determinants. Now I'm going to turn the focus to, what are the current and suggested policy strategies that could address disparities going forward? And I'm going to highlight 7 strategies. There are others, and briefly discuss them. So the first, Diana talked about equitable access to COVID-19 testing. This is vital because nearly every public health practitioner believes that an effective response to COVID is going to require regular and repeated testing of the population. And it's critical that testing sites be accessible to communities of color who have been disproportionately impacted. And unfortunately, that's not been the case across the country. Diana referenced some examples from New York, and here's a similar example from Chicago, where the first 4 COVID testing sites, none of them were located in predominantly Black neighborhoods, though Chicago's Black community has been heavily affected by increased infections from COVID-19. The second strategy is related to targeting resources to safety net institutions. And that is exactly the opposite of what the Coronavirus Relief Act has done. It's allocated funding according to total revenue, which means that hospitals that have higher shares of commercially insured patients, these are usually hospitals who have more financial reserve, those are the institutions that have gotten more money. And that's wrong in my estimation. This graph shows very clearly that hospitals with the highest share of private insurance revenue, which are the best able to weather the storm from COVID-19, have gotten more than double the amount as hospitals with the lowest share of private insurance revenue. And including a recent article in the New York Times that has documented that for-profit hospital chains that have been supported by private equity and are sitting on reserves of up to $9 billion have gotten a large fraction of coronavirus relief funds. So that is, if our goal is to target hospitals and their patient populations that are most in need, that's a policy mistake that should be corrected. We should also address underlying economic injustice in terms of the impact of COVID-19. That includes extending unemployment benefits, which are set to expire next month. Hazard pay, paid sick leave is a really important issue because the U.S. is one of the few high-income countries in the world that lack universal paid sick leave, which means that workers often have to choose between a vital paycheck or exposing their coworkers to infection. And that has implications for how we respond in the transmission of COVID-19 over time. So paid sick leave is important. And then employment for contact tracing and community health workers in disadvantaged communities. And addressing housing instability. There's been a rapid spread of infections among homeless populations, particularly those who are using shelters. So in terms of preventing spread, we need to think about how to isolate populations that are marginally housed so that we can address the spread among those communities. We talked about expanding health insurance coverage. There are a number of ways to do that, either expanding Medicaid coverage or policy proposals to lower Medicare age eligibility as recommended by presidential candidate Biden, or proposals to extend single payer coverage. And there's also issues with underinsurance in terms of the co-payments and deductibles for COVID-19 and testing and treatment, which should be addressed. Otherwise, those most in need will forego treatment. And then, applying an equity lens to the pandemic response, including task forces and community partnerships that can address disparities for communities of color, as Rhode Island has done. Rhode Island has a health equity task force, and that every state and local decision and federal decision that's considered in terms of reopening the economy, easing distancing measures, or access to vaccination if an effective vaccine becomes available, all of these decisions need to consider health equity in terms of how to proceed. And that these decisions have to include voices from impacted communities. Diana talked about data with respect to deaths and hospitalizations by race ethnicity. We still do not have complete data for cases and access to testing by race ethnicity. And that needs to change because it's very difficult to formulate effective policy without reliable data. And as a public health researcher, I believe in the power of accurate and reliable data. This is a screenshot from the CDC website on cases by race ethnicity. And you'll note in the footnote, it says, race ethnicity only available for 42% of people. And that's unacceptable, and we need to do better on that front. And then finally, the long-term goal is to dismantle structural racism. And the events of the past few weeks, including the murder of George Floyd, Ahmaud Arbery, Breonna Taylor, and many others who were never filmed, is the latest example of the structural racism that infects nearly every aspect of American life, including healthcare, housing, wealth, education, exposure to police violence. All of this undermines health, and anti-Black racism is a public health problem. So it's really up to all of us and to the institutions that we're part of to actively fight against racism, because the consequences for health disparities are enormous, as shown by this haunting New York Times cover that lists 1% of the 100,000 deaths that have occurred due to COVID-19. The stakes are high, and it's critical that we address them. Thank you.
Thank you so much, Diana and Amal. This was really great. And silent applause. I want to remind the listeners that please put your comments and questions into the chat function. We've had some questions about the availability of slides, and I just want you all to be aware that these sessions have been recorded and are available for on-demand viewing, and also CME credit, and the website is listed in the chats function. First question is, are there any studies or interventions that you've seen that directly address health disparities associated with COVID-19 that y'all think are especially exciting or hopeful? You listed a lot of things there, Amal. Are there ones that are especially promising?
Well, I can take that. I think, unfortunately, what we're finding with respect to COVID-19 is that, there's just, people are just learning about the disease. We're simply trying to figure out what is COVID-19. So if you notice, there were initially, based on the data we're getting from China, there was a lack of concern, for example, for younger individuals dying from COVID or dying from COVID-19. And then that changed when we started to see cases emerge in the US. So most of the studies that I've seen, that I've come across, have simply been trying to figure out what is this disease, and to sort of just, sort of get a sense of who the disease is affecting, and to sort of understand what the disease does to the body. I haven't really seen studies that have done, really any, interventions per se. I don't know if Amal wants to touch on that.
So Diana, I agree with everything you've said. Most of the work that I've seen so far has really been describing the problem. Maybe a few have described some mechanisms, but I have not seen any empirical work of effective interventions to reduce disparities related to COVID-19. It's so early in the pandemic. I think there's just rapidly emerging descriptive studies about the extent of disparity, and really everything that I've seen as a disparities researcher, none of it is surprising, but it's been incredibly troubling.
So another question is whether Rhode Island now reports racial and ethnic differences in testing. And also, is this based on self-reported identification?
Well, unfortunately, when it comes to information on testing by race ethnicity, the most recent data that I found, I think there were only 4 states that were presenting that data. And actually, the report form from the CDC that should be collected when people present for testing does have information on race ethnicity. It's unclear why all of the states are not reporting that data, even getting the data actually on deaths, race ethnicity by deaths and cases. there was quite a bit of effort that had to go into that in terms of senators writing, and people really saying we need to know what's going on. Because initially there were reports in major cities where we started to see a high number of African Americans in Milwaukee, Wisconsin, in Chicago, for example, and there started to be more of a push for data on COVID-19 being released by race ethnicity. And based on some of the most recent data, I believe is Illinois, Kansas, Delaware, and I think one more state that there are only 4 states, I believe, that's reporting this data on testing. So we don't have that.
And then a related question, what data on risk factors are available among Rhode Island specifically? And following that, there is a link to Rhode Island information, but I'll address that to you.
Well, so most of the data, unfortunately, Rhode Island is not very different from the other states. Most of the data that we are getting, typically is just reported by race ethnicity, and also by, we do have some data, as I presented earlier, with respect to where we're seeing these cases, whether in more, urban areas where we see higher numbers of certain, racial ethnic groups. But Rhode Island, I haven't seen as much data as I would like. I have been in contact with people at the health department, and this is certainly something, for example, being very interested in looking at hospitalizations. What are we seeing with hospitalizations in Rhode Island? What are some of the conditions? Who's presenting? And I haven't been able to get access to some of that data, but there are people at the health department that I have reached out to. And so we're hoping to get that information soon.
About another question, about a month ago, the governor reported 5,000 letters going out to test asymptomatic people in Rhode Island to gain insight into prevalence. Was this survey representative of all of the ethnic groups in Rhode Island? And were there enough members of all of the races and ethnicities? And do we have the results yet?
So I have not seen the results. And I think it's really important to make sure there is representative testing for a lot of different reasons. Scientifically, you want a representative sample of the population. But, I always also ask about, how, in what way are people being contacted? And is the language that explains the rationale for testing written in a way that's accessible? And, as Diana highlighted in her talk, there's a lot of distrust of minority populations with the healthcare system for good reason. And so I think that's going to be a really important issue to address, is the lack of trust and how to make sure that testing, and especially serologic testing, is accessible to a representative population, and particularly those communities that have been most impacted.
Along those lines, do we have a sense of disease incidence and death rates among undocumented individuals?
I'm not aware of any disaggregation by either citizenship status or by documentation. I have not seen it. As we've kind of alluded to in this talk, the data collection efforts are very uneven across the United States. And they very much depend, they're state by state. Many states are not reporting data on testing. One thing that's been kind of surprising is why Medicare has not reported more data stratified by race ethnicity. The reason I mention that is that Medicare has invested a lot of effort in collecting rigorous and reliable information on Medicare beneficiaries' race and ethnicity, using a variety of methods, including some indirect methods. And I have not seen a comprehensive report from Medicare. And for those of us who study, disparities in the Medicare program, it's been kind of a surprise. why they have not taken the lead on producing comprehensive data across the entire United States.
Well, another reason too, in terms of the documentation, is, as I mentioned, there is a concern among populations that if they get tested, there are concerns about, then being detained. And so I think there's been more of an effort to simply encourage people to go to get tested rather than collect data in terms of their immigration status.
Okay. Well, lots and lots of questions here. So, why are testing sites not located in a convenient place for minority communities? Why are they in suburban Walmarts?
Well, I think, again, that speaks to the disparities when we think, again, to sort of these structural issues when it comes to health and to access. There was a very interesting paper article that came out of NPR that actually motivated me to start to look more into this issue of testing. And this was in Tennessee, Nashville, Tennessee, where the Harry Medical School, which is a historically black historically black school, where they were trying to get a testing site for weeks and had difficulties getting testing supplies, getting kits, while at the same time, Vanderbilt University across town has easily set up sites. So again, there are real concerns in terms of, really thinking about who really needs to get tested and really making an effort to reach people where they are. The Washington Post also carried a really interesting article on Louisiana, where I believe the mayor of Shreveport just randomly started to map who was getting COVID-19, and he was finding that this was occurring predominantly with among African Americans, and really wanted to push and really pushed and said we need to do more in terms of testing, and didn't get the support he needed until much later. So I think this also speaks to some of the structural issues with respect to thinking about who gets access to testing. And even as I talk to some of my colleagues, there are concerns too about if we do get a vaccine, who is going to get access to that vaccine.
So those are great points. I just would only add one thing, which is the first site in New York that had COVID-19 testing was a drive-through testing site. That's also true in Rhode Island. The first site was a drive-through testing. You need a car to be able to do drive-through testing. You cannot walk out to Lincoln to get tested. And so that's why I was heartened that the second site was a walk-in site in South Providence. About 25% of the residents of Central Falls, Pawtucket, and Providence do not have access to regular automotive transportation. So you got to be thinking about that when you make a decision about where to locate testing sites. And that's why I think there needs to be a dedicated focus on disparities and on health equity. All of these decisions need an equity lens. So you prevent what happened in other communities around the country where sites were not located in the communities that were most impacted by COVID-19.
So there's a comment here. People who are undocumented do not benefit from most worker economic social protections that were mentioned. Are there recommendations to extend economic and social protections to undocumented workers in this political climate?
Well, I mean, we already saw, like I said, with the stimulus from the First CARES Act, that unfortunately there were people who have been working here for years that did not get the stimulus. And I think that I think if people are here, they should get the money, they should get these protections. And there's a lot of concern because I believe the paid leave, I think this paid leave, which is about $600 a week, I think that is going to end pretty soon. And again, this was not extended to people, who are working in the U.S. And I don't think that I don't understand why that needed to be included as a stipulation in the census. I mean, sorry, in the stimulus.
So can telemedicine increase healthcare access for minorities? Do you think that our healthcare systems will eventually embrace telehealth on a larger scale, and will this improve matters?
Well, there's no doubt that the pandemic has accelerated the use of telemedicine. And I believe, looking into the future, there's going to be more telemedicine because of this profound change that many of us as providers are now experiencing. My concerns about telemedicine is that, you need an internet connection in order to view your provider. So what about people where there's a digital divide? And so I think we need to very seriously consider about whether telemedicine, while increasing access for some populations who have transportation barriers, can also widen disparities among those who don't have regular access to the internet to be able to facilitate telehealth visits.
I think also the concern for me is, to a certain degree, medicine being more impersonal. I think there's something in terms of, building a rapport with your patients. I think that may be a little more difficult to do if you're relying solely on telemedicine.
So along the lines of never waste a good crisis, why has this remarkable disparity in access and outcomes that is known and has been known for such a long time not triggered action yet? How can the current COVID-19 and police violence problems help those who have been complacent take action?
I mean, well, the truth is, in terms of health disparities, or I think what was it? In 1985, there was the Kessler report that talked about Black and minority health. There's the American Health Dilemma that was written in terms of highlighting what we've seen with respect to distrust with the healthcare system. I do think that this time around, we are seeing demonstrations not only in the U.S. But internationally, in terms of really people really highlighting the importance of social justice. And so we hope that this will spread. Not only the focus has certainly been rightfully so. Looking at the police. And we know that in Minnesota yesterday, for example, the city council decided to dismantle the police force. We don't know how that is going to work, but so we hope that, this will sort of move people beyond only looking at, just policing, but also looking at other institutions that need to, that sort of need to be reorganized, and that are thinking about these issues, these social determinants of health, and thinking about how we then create a better health system so that we don't continue to have these disparities.
So there's a couple of questions about childcare and whether support for childcare might, along with paid time off and hazard pay, would that mitigate some of the disparities in the COVID-19 infection and mortality rates?
So they could, but I just want to return to that last question because I think it's really important about this moment.
Okay, sorry.
And why disparities have remained stable and why there has not been concerted action to address disparities. And I think part of this, the explanation is that there hasn't been the level of kind of public awareness and outrage that we're seeing right now. And I sort of think through, what have been the most effective actions over, say, the last 60 to 70 years that have addressed health disparities. And I would say the civil rights movement and a lot of the accompanying policy actions following the civil rights movement have made an enormous impact on health disparities, particularly the passage of Medicare and desegregating hospitals in the South.
Right.
And so this moment's really critical because I have never seen this level of coverage and awareness and interest about not just health disparities, but the overall level of systemic discrimination and racism in our country and what we can do to solve it. And so, government's always a lagging indicator. It starts with kind of public awareness and action, and then governments get forced to respond, which is what happened in the civil rights movement. So I think this isn't a moment to really think very carefully about, and that it can spur important change. I'm hoping it spurs important change.
Wow, that's a really important comment. And perhaps on that note, we should close with a hopeful view toward the future that this attention will, in fact, make a change. And thank you both so very much. And thank you so much for the participants for all your kind comments. And as I mentioned earlier, the presentations will be available online within a week or so. And we really thank everyone for your kind attention. So bravo.
Thank you. Thanks, Sharon. Thanks, Diane.
Okay.
Thank you.